Rexis, mastering the circle. Modern cataract surgery has given more importance to the placement of the IOL within the capsular bag. Capsulorhexis thus has become one of the crucial steps today. Beginners tend to face a solid brick wall when it comes to making a rhexis. This video aims to tear down that wall. While a femtorhexis is humanly impossible, we can always strive towards perfection. Practice makes perfect, and this starts in the wet lab. The idea of practicing in the wet lab is to improve hand-eye coordination, to get a feel of the tissue, and to see how the flap behaves with different direction of force. In the wet lab, we can practice rhexis in a goat eye and a human cadaver eye. The goat eye, unlike the human eye, has a very elastic and strong capsule, so formalin should be injected first to make the ALC more fragile, and then rhexis can be practiced. Human cadaver eyes which are not eligible for transplantation can also be used. The corneoscleral button is first excised and the iris is peeled off to expose the lens. Then the rhexis can be practiced in an open sky method. If the access to a simulator is available, it is a wonderful tool for anti-tremor training and to practice rhexis. Beginners are advised to try rhexis through multiple ports, both clockwise and anti-clockwise, if possible alternating between the hands. In the absence of these facilities, rhexis can be practiced on an empty box with cellophane covering, commonly an IOL box. The cellophane cover of an IOL box can be used for rhexis practice in the wet lab under the microscope or even at home using a magnifying loupe. It sort of mimics the feel of the lens capsule and helps to improve hand-eye coordination. To make your own cystotome, bend a 26 gauge needle with an artery forceps. The tip is first bent at or slightly less than 90 degrees. A second bend is made near the hub at 45 degrees. It is very important to make sure that both the bends are in the same plane as shown here. After all this practice, case selection plays a very important role. Criteria for case selection includes patients with a well-dilated pupil and preferably immature cataracts with no other comorbidities. Making the invisible visible. Continuous curvilinear capsulorhexis can be done against the red fundus glow. This is suitable in eyes with immature cataract and requires a microscope with retroillumination. Here, we can see the rhexis margin clearly delineated against the red glow. If the red glow is not seen, the anterior lens capsule can be stained with trypan blue for better visualization. The dye can be injected either with or without a small air bubble. We should allow it to stand for 30 seconds to 1 minute for good staining. Washing with balanced salt solution prior to injecting the visco is recommended to prevent clumping of the dye under the iris, which might escape in subsequent steps. Staining helps by giving better contrast and makes the capsule easier to tear. Techniques. Rhexis can also be done using a capsule holding forceps. It gives better control over the flap as compared to a cystotome. The ALC is first pinched to raise a flap. The end is grasped and continued in a circular movement as demonstrated here. The trick here is to hold the flap closer to the advancing edge to get better control. When doing rhexis from the main tunnel, initiate the rhexis a few clock hours ahead of the section. The flap is raised and flattened. A combination of ripping and shearing force gives good control over the advancing flap. We can proceed in a clockwise or a counterclockwise direction. At the end, it is completed from an outwards to inward direction. If we start the rhexis elsewhere, while moving the flap near the section, there is bunching of the flap and the flap can escape through the main port, which can result in a rhexis extension. To manage this, visco is injected gently to flatten and reposition the flap, and then rest of the Rexis is completed through the side port. Doing Rexis through the side port offers the advantage of greater anterior chamber stability and the flap remains well flattened. However, because of limited maneuverability, it is difficult to make a large Rexis, and this technique requires greater control on the surgeon's part. Overcoming obstacles. Now we see how to make Rexis in some common yet difficult situations that surgeons are likely to encounter. While making a Rexis, if the surgeon feels it is not adequate in size, the edge of the advancing margin is lifted carefully to slightly extend the Rexis using a cystotome, and then continued the same way. Alternatively, we can do a helical Rexis by spiraling out the flap till the desired size is achieved. Although time-consuming, beginners are instructed to try this method initially to avoid Rexis extension. If the surgeon feels that the size is inadequate after the completion of the Rexis, a double Rexis can be attempted. In case of phaco, this can be done after the IOL placed in the bag by making a small nick with Vanna scissors to raise a thin flap, which is then peeled using forceps. Alternatively, this can be done using a cystotome or even an irrigation aspiration cannula. In manual small incision cataract surgery, if the nucleus is large, double Rexis should be done before any attempt at nucleus delivery to avoid compromising the bag. In case of an extending Rexis, the aim initially should be to use ripping force and bring it back to the desired size using a cystotome. If there is any resistance, use a capsule forceps by holding the flap as close to the advancing edge as possible to rip it back. In case of a small pupillary size, the Rexis can be done by maneuvering the cystotome under the iris. It is always better to stain the capsule in these situations to get an idea on the size of the Rexis. This requires a certain degree of experience or things can go horribly wrong. The other option would be to use iris hooks to retract and create enough space to proceed with Rexis as usual with either cystotome or capsule holding forceps. Finally, we see how to do Rexis in an eye with zonular dialysis. The principle here is to start the Rexis before the area of dialysis. The flap is continued slowly in the area of the dialysis and then continued over the area with intact zonules. It is important to maintain adequate anterior chamber depth using visco. It is to be noted here that the Rexis in the area of the dialysis will be straighter. The rest of the surgery can be completed as usual with or without a CTR. Now that the video is over, it's up to you to practice and really master the circle.